Hey guys, let's enjoy the chest radiographs with Dr. Y. Today's session is 23, mediastinum, one of the four. Let's look at this chest lateral film. This is the usual concepts of mediastinal compartment. This is superior, middle mediastinum, and anterior and posterior. It is easy and simple. This chest lateral film-based concept of a mediastinal compartment is defined by Fractional Society as like this: anterior compartment, anteriorly the sternum, and posteriorly anterior pericardium and ascending aorta and brachiocephalic vessels. Middle compartment is between anterior and posterior, simple. Posterior compartment is between posterior marginal pericardium and great vessels and posteriorly by thoracic vertebral body. Superior mediastinum is above the sternal angle or T4 or 5 vertebral body, or just simply above the aortic arch. But there is a problem with this compartment concept because there is no exact anatomic boundaries and barriers in this lateral film-based concept of mediastinal compartment. This slide is about the mediastinal anatomy written on Wikipedia. Mediastinum lies within the thorax and is enclosed on the right and the left by the pleura. Mediastinum is surrounded by the chest wall in front and lungs to sides and spine at the back. Mediastinum contains all the organs of the thorax except the lungs. Mediastinum is continuous with loose connective tissues of the neck. Let's look at the Mediterranean Sea. It is surrounded by the lands on the north by southern Europe, on the south by the North Africa, on the east by the Western Asia. I'll introduce you the new recent concept of a mediastinal compartment by ITMIG. First, the prevascular compartment, almost similar as anterior mediastinal compartment. What's important is posterior boundary, that is, anterior aspect of the pericardium, as it wraps around the heart in a curvilinear fashion. And second, the visceral compartment, and that is similar to middle mediastinum. That is, posterior boundary is vertical line connecting a point on each thoracic vertebral body 1 centimeter posterior to its anterior margin. And third compartment, the paravertebral compartment, is just similar as posterior mediastinal compartment. Why the ITMIG, International Thymic Malignancy Interest Group, developed this new concept? Because we are living in the cross-sectional imaging CT stage, and almost anything about mediastinal tumor is defined with the CT, not by the chest lateral film. So let's look at this sagittal CT image. The first one, burgundy color of anterior portion, is the prevascular space, prevascular compartment. And second, this blue zone. This blue zone is until the anterior 1 centimeter of vertebral body as the visceral space, visceral compartment. And the last one, posterior portion, as yellow portion, that is paravertebral compartment. They divide the three compartments as prevascular, visceral, and paravertebral compartment of mediastinum. This is written in B.W. Carter et al. At Radiographics year 2017. Let's look at this axial CT image. This burgundy color, just anterior of pericardium, wrapped around pericardium, is prevascular space, prevascular compartment, and the other, until the 1 centimeter posterior of anterior margin of vertebral body, as visceral compartment, previously mediastinum, and posterior to this green line, this line named as visceral paravertebral compartment boundary line. This yellow portion is paravertebral compartment. So, prevascular, visceral, and paravertebral compartment is a new concept of mediastinal compartment. Just simply memorize and print on our minds. Let's do it. Let's look at this new slide. What's in there? At prevascular space, there are thymic tumor, germ cell tumor, lymph node disease, and goiter. In visceral compartment, A, vascular compartment, heart, superior vena cava, aorta, pulmonary artery, thoracic duct. Non-vascular compartment contains trachea, carina, esophagus, and lymph nodes. Paravertebral compartment contains neurogenic tumor, osteomyelitis, hematoma, extramedullary hematopoiesis. There are some characteristics of mediastinal tumor masses on chest radiograph. First, different tumors according to the different compartment. B, mediastinal tumors often ambush on chest frontal PA radiographs, so we sometimes need a lateral view. C, mediastinal line of retration is so important for mediastinal tumors. D, mediastinal tumors are usually broad-based, showing obtuse angle rather than acute angle with sharp, clear margin. Now we understand why the normal anatomy of chest PA and lateral films are so important. Because mediastinal tumors are here, usually hiding in here, sometimes bulging out here. That's why the name of this margin is so important. Left subclavian artery, aortic arch, pulmonary trunk, flat sunken left atrial appendage, left ventricle, right atrium, superior vena cava, and right brachiocephalic vein. That's why this line is so important. And let's look at the lateral film. Retrosternal space, retrosternal triangle, retrocardiac space, or retrocardiac triangle. That is the place we can find mediastinal tumors. To find out the mediastinal tumors on chest radiographs, especially frontal PA view, we need to understand these concepts. First, mediastinal lines, obliteration of mediastinal lines, and silhouette sign, the meaning of silhouette sign, the concept of hilum overlay sign, and Mach band effect, and cervical thoracic sign, thoraco-abdominal sign. If you need more, please go back to my previous sessions. What are the prevascular compartment tumors? Most common tumors are thymic epithelial tumors and malignant lymphoma, and sometimes intrathoracic goiter. And rarely we see germ cell tumors. Medical students used to memorize the anterior mediastinal tumors or prevascular compartment tumors as 4T, thymus, thyroid, teratoma, and terrible lymphoma. Terrible lymphoma. Isn't it funny? As memorized lymphoma as T, terrible. Let's see the real case of the prevascular compartment tumors. This young man's chest PA, frontal chest radiograph, does not show anything abnormal, looking normal. Regrettably, we don't have lateral films. As usually recently nowadays, most of the hospitals have tendency to go directly from PA view to CAT scan. This axial contrast enhanced CAT scan shows solid mass, about 2 cm, relatively diffuse, homogeneously enhancing soft tissue tumor with calcification. It was proven at thymoma B1. This is prevascular space tumor of thymoma. Let's see the second case. What do we see? About 3 cm. Mediastinally broad-based, well-defined, homogeneous mass. Yes, mediastinal tumor. An aorta line is preserved. That means not posterior. And heart margin is obliterated, probably anterior location. And we see the normal left pulmonary artery. Left pulmonary artery is okay, not in contact with the tumor. That means this mediastinal tumor is anterior location, prevascular location. And look at this lateral film. It's in retrosternal location, so prevascular compartment tumor. On this axial contrast-enhanced CAT scan, we see the round, well-defined margin, prevascular on location, not touching pulmonary artery, not touching aorta. Yes, anterior location. Retrosternal triangle. This low density was negative density. That means this is fat density. What is your diagnosis? Yes, you are correct. Let's see another case. This is an old woman with large, well-defined mass, right side, lower side. How about the right heart border? Yes, obliterated, silhouette positive. How about the pulmonary artery of the hilum and lower lobe? Yes, they are also preserved. That means this is anterior location, well-defined mass touching right heart, not touching hilum and posterior. Let's imagine on the CT findings. On this axial CAT scan, enhanced CAT scan, we see the fluid density here touching right heart border, not touching pulmonary arteries. Yes, prevascular compartment, congenital cyst, hilum overlay sign. Yes, silhouette positive sign. Let's go to the second compartment. Visceral compartment tumors. The most famous lesions are lymphadenopathy, such as lymph node metastasis, small cell lung cancer manifesting as conglomerated lymphadenopathy, tuberculous lymphadenopathy, or sarcoidosis. And second, congenital cyst, such as pericardial cyst, foregut duplication cyst. And C, rare pericardial tumor. D, more rare neurogenic tumors such as vagal or phrenic nerve origin. Let's see the visceral compartment tumors. What do we see with this middle-aged man's chest PA film? Well-defined, obtuse angle, clear margin, broad-based, not in contact with right vertebral stripe, not in contact with right heart border, not in contact with right hilar pulmonary vessels. Where is it? Yes. You can imagine where this tumor is. On this axial contrast enhanced CAT scan, we see the 4 cm well-defined homogeneous cyst here, subcarinal area, normal right pulmonary hilum, not in contact with the cyst, and right paravertebral stripe is also not in contact with the mass. This is here, visceral compartment congenital cyst, most probable location of bronchogenic cyst. Let's look at this old man's chest PA frontal film. Large bulging mass, broad-based on the mediastinal side, well-defined margin, obtuse angle, right paratracheal stripe obliteration. What is this? Where is it now? You can imagine. Visceral compartment. On this axial contrast enhanced CAT scan, we see the large lymphadenopathy, conglomerated lymph node enlargement of small cell lung cancer, obliterating right paratracheal stripe, behind the vessel, behind the great vessel. This is visceral compartment. It's a small cell lung cancer. Let's go into the last compartment, paravertebral compartment tumors. The most common tumor of that compartment is neurogenic tumors, such as nerve sheath tumor, schwannoma, neurofibroma. But when we compare the incidence with lung cancer, it is very, very rare. And 2, parasympathetic ganglion tumor, 3, sympathetic chain tumor, and non-neurogenic tumors all are very rare. What do we see with this frontal film? Large, dense mass, well-defined margin, broad-based, homogeneous density, clear left ventricular heart margin. That means this is in posterior location. And obliteration of aorta and obliteration of paraspinal stripe. That means this lesion is posterior location, posterior mediastinal tumor with most probable possibility of neurogenic tumor. And when we see on the lateral film, this is on posterior side, overlying the spine. On axial contrast enhanced CAT scan, we see the posterior paravertebral compartment tumor overlying with visceral compartment, homogeneous density, well-defined mass. with paraspinal stripe, aorta, line obliteration. Posterior compartment, paravertebral compartment tumor, most likely neurogenic tumor. What do we see with this young man's frontal chest radiograph? A well-defined 2 cm mass with a sharp border. The location is above the clavicle. That means this is not anterior prevascular location, not prevascular location, but paravertebral compartment location. This is, we used to say, thoracic sign. Let's look at the lateral film. This is head of the humerus. The tumor is this one. Yes. It's in the vertebral body side. Yes. It's paravertebral compartment location, probably neurogenic tumor. Let's look at the actual CAT scan. Yes, this is vertebral body. So this is paravertebral location, well-defined, sharp margin, solid tumor, probably neurogenic tumor. Now this session is over. You worked very hard. How do you feel now? Satisfied? Enjoyed? I hope so. Next session will be about more focused on anterior mediastinum, in other words, prevascular compartment tumors. Like, subscribe will be a big support to me. Thank you very much.